idea.
Okay. All right. Thanks everyone again for joining us for this California ACC medical education program titled Diabetology, Optimizing Cardiovascular Reductions in Patients with Type 2 Diabetes. The program faculty who are part of this are all from the California ACC prevention group, include Dr. Nathan Wong, John Baker, who will be speaking tonight. Other members of our program are mentioned there. Relevant faculty disclosures related to this program are listed here. And then accreditation information. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through the joint providership with the University of California, Irvine School of Medicine and the California chapter of the American College of Cardiology. The University of California, Irvine School of Medicine is accredited by ACCME to provide continuing medical education for physicians. The UCI School of Medicine has designated this activity for a maximum of 1.25 AMA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. This credit is also transferable to nurses and PAs. All non-physician healthcare professionals who attend will receive a healthcare provider certificate that you can submit to your own credentialing board to request transferable CEU. Other providers, such as pharmacists or RDNs, may request transferable CE credit from their credentialing board. And lastly, this program is supported by an unrestricted educational grant from Novo Nordisk. At the end of our presentation, we'll have the links and the information about claiming the credit for this evening's program. So tonight, the focus of this program, our objectives are to explain how to assess the risk of cardiovascular disease in persons with type 2 diabetes, describe the role of multifactorial risk factor intervention in reducing cardiovascular outcomes, analyze the role and evidence behind newer therapies for reducing cardiovascular risk in patients with type 2 diabetes, interpret healthcare disparities in underserved groups with high diabetes prevalence and cardiometabolic risk, and then finally, summarize current guideline recommendations for reducing cardiovascular risk in patients with type 2 diabetes. Tonight, I'll be the moderator for the session. And then at the end, after both of our presenters have presented, there is some case studies that we'd like to kind of use to reinforce the information provided tonight. So our first speaker is Dr. Nathan Wong, professor and director of the Heart Disease Prevention Program, Division of Cardiology at the University of California, Irvine, and also one of our co-chairs for the California ACC Prevention of Cardiovascular Disease Committee. Dr. John Baker, also one of the co-chairs for the California ACC Prevention of Cardiovascular Disease, and an invasive interventional cardiologist with Cardiology Consults of Orange County, California. I will stop my screen share and let Dr. Wong take over.
Okay, well, thank you very much, Dr. Kelly, and let me put this on slideshow. Okay, great. Thank you very much, Dr. Kelly, for the introduction, and it's great to be providing this program with you and Dr. Baker tonight, and also like to thank Leanna Kaling from the American College of Cardiology for all her help with organizing this, and it's great to have all you on this evening. We're going to be talking about really how to optimize cardiovascular disease prevention in our patients with diabetes. And I guess what happened is I need to start here, so that's where I'm going to start. So I think as everybody is well aware, we have a continuing epidemic of diabetes throughout the world, with estimated prevalence expected to be, it's around 8.5% now. expected to rise to 9.6% by the year 2045. And most of these cases actually are in the Western Pacific and Southeast Asia regions. We have a substantial important disparities in diabetes prevalence here in the United States, quite a variation in prevalence, being highest in American Indians or Alaskan Natives, and next highest in Hispanic individuals and Black individuals as well. Asians and white people are have somewhat of a lower prevalence. There are also social determinants of health, including education, that appear to be inversely related, with prevalence of diabetes here being prevalence being lowest in people with more than a high school education and highest in people with less than a high school education. I think we all recognize that cardiovascular outcomes are the principal causes of mortality in people with diabetes, particularly heart diseases and cerebrovascular diseases. Importantly, this large UK cohort, which reported out several years ago, actually showed that of the first manifestations of cardiovascular disease, peripheral arterial disease and heart failure were the most common first manifestations, followed by angina and non-fatal MI. So this really suggests the need for earlier screening of subclinical peripheral arterial disease and heart failure, and obviously consideration of newer therapies to address these various conditions. Now, this paper that we published more than 15 years ago shows a stepwise gradient in risk of mortality from coronary heart disease, cardiovascular disease, and all causes, as you go from having none of these conditions to metabolic syndrome, diabetes without prior CVD, CVD without prior diabetes, and a combination of cardiovascular disease and diabetes, remember, really represents a very high risk condition. So these people obviously need the most intensive therapeutic intervention. The Framingham Heart Study long ago here demonstrated, using 36-year follow-up of their cohort, an interesting point, that the fact that diabetes is a stronger risk factor for cardiovascular outcomes in women than in men. You can see here overall, diabetes is associated with a 3.7-fold greater risk of all cardiovascular events in women compared to 2.2 in men. And you can see, particularly for heart failure and peripheral arterial disease, the risk conferred by diabetes was substantially more for women than for men. Important in determining how intensively to treat, we always need to start with estimating a person's atherosclerotic cardiovascular disease risk. Remember, this is the first, this is the foundation of preventive cardiology, because the estimated risk helps us determine the intensity to treat. And the currently used risk calculator in the United States, there are others, of course, around the world that are oftentimes used, but here in the US, we use the pooled cohort equation, or ASCVD risk estimator. This provides a 10-year ASCVD risk for people aged 40 to 79, and a lifetime risk for people 20 to 59. And you can see the different inputs that are required. It's important to recognize, though, that diabetes in this equation is indicated, and in many is a binary factor. So it does not include other important information such as A1C and the duration of diabetes, and remember that most of these scores, including this one, are not appropriate for use in people with pre-existing ASCVD, who are by definition high risk. So we use this in primary prevention, but this also includes people with diabetes without ASCVD. In secondary prevention, people with clinical ASCVD, and I'm not going to go through all the treatment algorithms here, but it's important to recognize now that our guidelines divide people into people at very high risk of ASCVD and people at technically not at very high risk, still at high risk, but just not at very high risk according to the definition. The main difference here being that the very high risk people, after considering high intensity statin and ezetimibe, could be considered for a PCSK9. But one thing, so this is how we define the very high risk people with multiple major ASCVD events, so 2 or more of those, or one of these and 2 or more of these high risk conditions, right? So this is where actually diabetes fits in. So if you have, for example, you have a history of a single ischemic stroke, but you're over the age of 65 and you have diabetes, technically that person would be considered very high risk. So this will, we'll return to this later when Dr. Baker talks about different therapeutic approaches. I might mention that another risk score that does have diabetes specific factors such as A1C and duration of diabetes, even even history of atrial fibrillation is included here, is a UK-PDS risk engine that predicts a 10-year risk of both fatal and non-fatal coronary heart disease and stroke. But clearly there is a need for perhaps a US-based pooled cohort type of equation. We've been doing some work on this in my research program. There are various risk enhancement factors that our current guidelines states can help inform the treatment decision regarding preventive therapy, such as statin therapy, particularly in younger individuals with diabetes. So, for example, a long duration of diabetes of 10 years or greater for type 2 diabetes. In fact, Dr. Rana, who is also on our faculty and his great work from Kaiser Permanente, Northern California, did show that a 10-year duration of diabetes does seem to predict a coronary heart disease risk equivalent. Also, albuminuria, EGFR levels indicative of chronic kidney disease, retinopathy, neuropathy, and an ankle brachial index of less than 0.9. What's not shown here is actually coronary calcium. And I bring this up because there is a fair amount of evidence that this can actually be a very important risk stratifier. An example comes from a paper that our group published 10 years ago that showed a great heterogeneity in risk of coronary heart disease as you go from having a 0 calcium score where the annual CHD event rate is only 0.4, but this is increased tenfold in people with a coronary calcium score of 400 or higher. So clearly the amount of subclinical atherosclerosis indicated by coronary calcium can be a very important risk stratifier for thinking about the the initiation and of statin therapy, particularly in younger people where it's not a definite indication, but the intensity of statin therapy in people over the age of 40, where we we typically consider at least a moderate intensity, but if they have a high calcium score, then that would be suggestive of even more intensive therapy. And there are guidelines going back to 2010 that indicate that a calcium score may be useful for risk stratification in intermediate risk individuals with diabetes. This was another paper we published last year that showed how actually a calcium score of 100 or higher was an even stronger predictor of total and cardiovascular mortality in women with diabetes compared to men with diabetes. So we think that this might potentially explain some of the excess risk where diabetes is a stronger risk factor in women than in men. Important to understand is that there is oftentimes a clustering of risk factors in people who have diabetes. So in this in this NHANES study from about 10 years ago, it showed that fully 20% of people with type 2 diabetes also had hypertension, obesity, and hyperlipidemia. And another 35% or so had at least 2 of these conditions. So in a person with diabetes, it's critical that we also assess for the presence of other risk factors. And one thing we know, though, is that risk factor control is quite variable. We have, fairly good control of A1C. This is from data we published in almost 75,000 people from the Diabetes Collaborative Registry that was initiated by the ACC in collaboration with other major societies. About 3/4 are at acceptable A1C targets, 70% at the older blood pressure target, but this drops to 40% if you look at under 130/80, and about half are at reasonable LDL cholesterol targets. If you want to set a target, of course, our most recent guidelines, remember, do not specify targets, but if you were to consider desirable levels, most people would consider an LDL under 100 or under 70 for those people who have atherosclerotic cardiovascular disease, and about 85% non-smoking. But the critical point here is that if we look at composite risk factor control, only 25% and 15% if you use this lower blood pressure target, which remember is a new target since 2017, are at acceptable levels for A1C, blood pressure, and LDL. If you add non-smoking status, this falls even lower. So the point here is we really have to consider diabetes as much more than an A1C or a blood sugar problem. Both providers and especially patients need to understand that diabetes is a cardiovascular problem, and if we're going to improve outcomes, we really have to look at the major cardiovascular risk factors that have an impact. We know that if the more of these risk factors under control, this is from a pooling of several prospective studies that we did a few years ago. Over half of these individuals, more than 2,000 of them in total, but over half were Black. And we were able to show that actually risk factor attainment was worse. And the point here is that the greater the number of risk factors controlled, the lower your risk. So compared to people with none of the 3, A1C, blood pressure, or LDL at target, if all 3 of them were at target, your multivariable adjusted risk were about 60% lower for both cardiovascular events and coronary heart disease events. So this was, important and really underscores the the value of multiple risk factor control. And in fact, the Black subjects in our study actually benefited more in terms of risk reduction. And that really corresponds nicely with what was a fairly small but still notable clinical trial done in Europe called the Steno-2 study, which assigned people to intensive multifactorial risk factor intervention and compared to conventional management showed a 53% risk reduction. And in fact, following these individuals up beyond the conclusion of the study for another 13 years, there was a dramatic reduction in total mortality. So this underscores what we might consider a legacy effect, the fact that the body remembers if you're doing a good job with lifestyle and clinical management of risk factors, the body remembers that and continues to benefit even after the conclusion of a randomized trial such as the Steno-2 study. Just a little bit about lifestyle intervention before I turn this over to Dr. Baker. Certainly what's relevant are the AHA-ACC lifestyle management recommendations, such as the DASH diet, the USDA, AHA type of approaches, physical activity, resistance training. And I have another slide on this that gives you a little more information. So in general, a heart healthy dietary pattern to not only improve glycemic control, but to achieve weight loss if needed and to improve other risk factors, as we talked about, is absolutely critical. At least 150 minutes per week of moderate intensity physical activity, or 75 minutes a week of actually vigorous intensity physical activity. We know that even moderate weight loss can have a dramatic effect. Here, a 15% weight loss can dramatically lower systolic and diastolic blood pressure, glucose, especially triglycerides, over a 40% reduction, as well as cholesterol levels. Not shown here, as we know that actually inflammation, remember diabetes is an inflammatory condition as well, and levels of C-reactive protein improve, and also insulin sensitivity improves from weight loss. The PREDIMED study was the iconic Mediterranean diet study that involved thousands of patients, and this involved people who were either high risk with diabetes or multiple risk factors. And what's shown is that a Mediterranean dietary pattern supplemented by either extra virgin olive oil or nuts reduced the primary endpoint of cardiovascular events by about 30%, although there was no significant reduction in mortality. Important to point out are the AHA 2021 Dietary Guidelines that were just released very recently, and these focus on 10 key points here. So adjusting energy intake and expenditure to maintain healthy body weight, very important for prevention and control of diabetes. Of course, plenty of fruits and vegetables, choosing foods that have whole grains rather than refined grains, and healthy sources of proteins, mostly from plants and fish and seafood, liquid plant oils rather than tropical oils, and minimally processed foods. Remember, these are what you're going to find on the outer rim of your grocery store. The processed foods tend to be in the frozen and the canned food sections in the center of the store. remember, minimizing intake of beverages with added sugars, and reducing sodium intake, minimizing alcohol intake. And important also in this guideline was pointing out that of trying to adhere to these guidelines wherever food is prepared and consumed, right? We have choices when we go out to eat, remember, that's very important. And finally, a little bit about tobacco cessation. The clinical visit should always include an encounter with a healthcare provider where you're asking and documenting current tobacco use status, advising and providing a strong message to quit, assessing readiness to quit. There will be some people who are not ready to quit, so you'll need to keep working on them, but people who are ready to quit, assess and negotiating a plan and providing them with the needed resources to help them quit, and arranging, of course, for follow-up visits. So these are some of the key lifestyle issues. Also, you know, if we had more time, we could get into psychosocial and behavioral issues as well, and how these can impact risk. But maybe we can leave that for the discussion. So I think with that, I'm going to turn it over to Dr. John Baker, who will talk about multiple risk factor management strategies for prevention of cardiovascular outcomes. So welcome, John.
Great, terrific. Well, welcome everybody. Let me see if I can get my screen shared here. Just one moment.
And I also want to welcome Dr. Polinopian, who is one of our faculty, to the panel as well tonight.
Okay, hold on a second.
Looks like you got it. I can see it.
Okay, got it. Switch this out. Second.
No, now we got the spreadsheet.
Okay, hold on a second.
Okay. If you want, I can share mine and you can tell me to advance.
I apologize. I thought I had this all set up. You can see my turtle there, I'm sure. So hold on just a second. Stop the share. Okay, so now I think we got it. Okay, so let's go.
No, I don't think I see the slides.
Okay.
Now. Okay.
You have slides now, correct?
Good.
Okay, perfect. Okay, so welcome everybody. So this is looking at what we can do about the risk factors in diabetics and diabetic patients. ABCs work. So these are the standard things that we know work for heart disease. A, assess the risk of a patient. B, assess the blood pressure, cholesterol control, diet, exercise, heart failure. The ABCDEFs are very important. And with now coming out of the pandemic, exercise is actually a really good thing to tell patients now, because now their patients are willing to exercise. But when you look at the magnitude of these effects, what you see is that if you have good blood pressure control, you reduce your complication rates up to 24%, reduce your risk of heart attack 39%. And then with blood pressure control, it's surprising how many patients don't have good blood pressure control, but with good blood pressure controls we'll get to, you can reduce your cardiovascular disease event by 51%, diabetes-related deaths by 21 and 32%, or stroke and diabetes-related deaths. With lipid control alone, coronary mortality is reduced by 35%. Cerebrovascular accidents are reduced by 53%. There's a large study called the Interheart study, which looked at the first myocardial infarction. 52 countries were involved with this study, 27,000 patients. They found 9 modifiable risk factors that were associated with the first heart attack of a patient: smoking, dyslipidemia, diabetes, hypertension, abdominal obesity, poor diet, physical activity, and excess alcohol consumption. And that was responsible for more than 90% of the risk of the first myocardial infarction. In diabetes, there's a heterogeneogy of effect of aspirin. So I'm going to kind of go over this. So aspirin, as we know, if you give aspirin, there's been some studies that look at variable risk reduction. So you have no aspirin versus aspirin. Some show benefit, some studies don't show benefit. What you look at is that there's an aspirin for diabetics. We can consider aspirin for patients who are at very high risk, like a 10-year risk of greater than 10% in those patients. There was a large study, which is the Ascend trial, which looked at aspirin in serious cardiovascular events in diabetics. So you can see on this axis, there are participants with events. And this axis, years of follow-up. You can see without aspirin, the risk is here, and then you add aspirin and your risk is lower. So the difference is 1.1%, the difference from 9.6 to 8.5. So you have a 1.1% reduction, but you also have an increase in major bleeding of 0.9%. So this is counterbalanced by the increase in major bleeding risk. So that's the issue with aspirin. Now, tight blood pressure control. So this was a study that used, it's part of the UK PDS study that looked at the complications from diabetics and hypertension. So there was 42,000 or almost 43,000 patients, or 4,300 patients with a mean blood pressure of about 160/94. They were defined as either tight blood pressure control, which is less than 150/85, versus less tight blood pressure control, which is 180/105. And the differences are startling. So the tight blood pressure control group had much less percent of any diabetes-related endpoint. The p-values are down here for each of the ones. Diabetes-related mortality was a reduction, but did not reach statistical significance at 0.019. There was a microvascular disease, retinopathy progression, vision deterioration, substantial reduction, stroke, and heart failure. So these are very substantial. And again, p-value of 0.0043 for heart failure. So blood pressure control makes a difference. Again, there's another study looking at blood pressure control in Accord, where it shows that this trial had 2 endpoints. One was the endpoint for cardiovascular events. So it did not reduce the composite of adverse events, which is but it did reduce the rate of stroke. So, so you can reduce your rate of stroke according to this study, the Accord study. Post hoc analysis, similar, that you can also do this in non-diabetic patients. So it also reduces the risk of stroke in non-diabetic patients. So the guidelines came out in relationship to these studies, and it shows that in adults, class 1 recommendations, adults with hypertension, antihypertensive drug therapy should begin at a drug pressure of 130/80 or higher, with a treatment goal of less than 130/80. In adults with diabetes and hypertension, all first-line agents are useful. Diuretics, ACE inhibitors, ARBs, and calcium channel blockers. ARBs or ACE inhibitors can be considered in the presence of albuminuria. Now let's move to statins. So statins are another thing that has been shown to substantially reduce risk. So major in this study, which was done published in Lancet, showed there was a significant reduction in major vascular events, a 21% reduction per 1 millimole of reduction in cholesterol. Now, I know we don't measure things in millimoles. We measure them in milligrams per deciliter. So if you take that number, the 1 multiplied by 18, you'll get milligrams per deciliter. So 18 milligrams per deciliter reduction in cholesterol will result in a 21% reduction in major cardiovascular events. or major vascular events and all-cause mortality in patients with diabetes mellitus. So these recommendations came out in 2018 in adults with 45 to 75 years of age with diabetes, regardless of estimated 10-year risk, moderate intensity statin is indicated. Class 2A in adults 45 to 75-year-old with diabetes, with an LDL of 70 to 189, it's reasonable to assess the 10-year risk of a first atherosclerotic event by using the race and sex-specific PCE to help stratify atherosclerotic events, which Dr. Wong has already gone over the excellent risk stratifiers that we have now. So if you do have someone who comes up with higher risk, they would classify themselves into another risk category where you may need to use more than moderate intensity statin, which we'll talk about. Patients with diabetes who have multiple risk factors, it's reasonable to prescribe high intensity statin, as we mentioned. Adults with older than 75 who are already on statin therapy, it's reasonable to continue. And adults with diabetes and a 10-year risk of 20% or higher, it may be reasonable to add ezetimibe to maximally tolerated statin therapy to reduce LDL by 50% or more. Improve It was a landmark study that came out, which looked at, in diabetics, looked at patients who had after 10 days from an acute coronary syndrome event. So it looked at diabetics versus non-diabetics in acute coronary syndrome. So 10 days after, they randomized, all patients got statins. They randomized the patients to get ezetimibe versus no ezetimibe. So the simvastatin plus the ezetimibe group is the darker color. Simvastatin alone is the lighter. So you see here, no diabetics, there's no statistical significant difference. But in diabetic patients, there was a significant reduction in mortality and event rate in the diabetic patients who get ezetimibe within the first 10 days after an acute coronary syndrome event. Another study looking at the PCSK9 inhibitors. So you look at evolocumab on the primary the endpoints. What you saw is patients who had diabetes versus patients without diabetes at baseline. So you see there's a significant reduction in death, stroke, MI, or unstable angina in patients with diabetes at baseline, with a 2.7% reduction, with a number needed to treat of 37. Without diabetes, you still have benefited at 1.6%, but the number needed to treat is higher. So again, you have a more favorable number needed to treat prior to getting a reduction in your risk for events in diabetics. Another landmark study that came out was the use of isopentyl or isopentyl ethyl, which is called the Reduce It trial. This was the inclusion criteria is age more than 45 with established coronary disease, or 50 years old with diabetes and one additional risk factor. The fasting triglyceride levels were 150, greater than 150 to or less than 500. To make note of this, the number was allowed to be decreased by 15 or 10%, such that the actual fasting level for inclusion was 135 to allow for inter-day variability in triglyceride measurements. So the third criteria is that the LDL-C is greater than 40 and less than 100 on a stable statin therapy, plus ezetimibe for 4 weeks prior to qualifying for measurement for randomization. So with the Reduce It study, there were some remarkable events. So just adding the isopentyl ethyl, what you found is that the patient who had placebo versus the isopentyl ethyl had a significant reduction in events. So a 24% relative risk reduction with a number needed to treat of 21, which is amazing. We don't have that with, that's close to things with defibrillators that we have to reduce risk of death. P-value is just terrific. So the p-value is the number of zeros here are just terrific. So this is something that significantly reduces the risk of stroke, death, myocardial infarction in the patients who are reduce-it candidates. There was some risk reduction in non-diabetics as well, but today we're talking about diabetic patients. Looking at the pre-specified testing, you can see that all of these endpoints essentially showed significant benefit in isocopentyl alcohol. The total mortality did touch the range of identity, but everyone else is, all the others shows significant benefits with significant p-values for every one of the endpoints that were tested. So the new guidelines that came out in regards to the isocopentyl, or multiple societies have done this. Now, the American Diabetic Society recommended that in patients with atherosclerotic disease with controlled LDL-C but elevated triglyceride between 135 and 499. So this number is pretty much the same in all the age groups or all the recommendations. Same thing, high risk patients with triglycerides should be considered in addition with a statin, 45 years or older with clinical, or 50 years of older with diabetes mellitus and one additional risk factor. This is just reading out of the inclusion criteria for the study. Same thing in the American Heart Association, American Clinical Endocrinologist, and it's 4 grams a day or 2 grams twice a day in maximally tolerated statins. Next, the 2021 expert consensus decision pathway for treatment of hyperlipidemia, which just came out in July of this year. So basically, if you have patients with hypertriglyceridemia, again, by the Reduce-It trial, defined as greater than 135, you rule out secondary causes, optimize diet and lifestyle, optimize glycemic control, and high-intensity statin. So consider ezetimibe if the 10-year risk is more than 20%. So again, this is age 40 with diabetes, probably 135 to 499, but 150 to 149 was, I think, that's studied in a study. Age less than 50 or greater than 50 with no traditional risk factors, LDL lowering approach was recommended. More than 50, one or more risk factor, triglyceride therapy plus the isocopentyl. So the new paragraph for residual risk reduction is maximally tolerated statin, ezetimibe, particularly in diabetics with acute coronary syndrome within the first 10 days after their acute coronary syndrome event. Isocopentanoic acid, which is similar to same as isocopentyl, which is a stable atherosclerotic disease, diabetes with one additional risk factor with triglycerides more than 135, and a PCSK9 inhibitor for stable atherosclerotic disease with additional risk factors or very high risk factors with LDL greater than 70 on maximal therapy. I'm not going to go through all these, but there's multiple studies now which are out looking at patients with diabetes to determine the risk. Some are ongoing, be published soon, but we know that diabetics have substantial reduction in death rate when things are done per prevention, as we talked about. Here's another new approach for reducing the blood glucose, and these are the ones that you're probably hearing about at your offices. The GLP-1 agonists or in the SGLT2 inhibitors. So I'm going to talk about the mechanism just for a moment. So the GLP-1 agonists, essentially, they stimulate insulin release by creating a substance called incretins. They also inhibit glucagon release. They reduce the blood glucose by that mechanism. So this is how the GLP-1 agonists work. The SGLT2 inhibitors work by the renal pathway, so they inhibit the renal reabsorption of glucose. So essentially what they do is that they work on the tubules so that the glucose that's in the tubules is less reabsorbed. So you excrete more glucose in your urine. The differences between these two is that you get a reduction in both are the same. You get a reduction in systolic blood pressure, total cholesterol, LDL cholesterol, both are the similar. Get a reduction in blood pressure with this. Weight reduction with the GLP-2, we're going to come back to that. CRP and BNP reduction in the GLP-1, weight reduction and decreased albuminuria. This slide is a kind of a busy slide, but basically it talks about what you do with patients who have atherosclerotic disease and are at high risk of events. So patients 18 years of old, you address it concurrently, you're already on optimal medical therapy, you lifestyle, blood pressure, lipids, and you're still elevated, then you recommend starting the SGLT2 inhibitor or GLP-1 with proven cardiovascular, depending on the patient's specific factors, which we'll discuss in a moment. Discuss patient related preferences and priorities, and you select either one of these two and you reconsider if the benefits outweigh the risks. Type 2 diabetics in patients with heart failure. It's important to look at the newer SGLT2 inhibitors and the GLP-1 therapies that can be used for those with diabetes who either have atherosclerotic disease or at high risk based on the risk factors and atherosclerotic disease, and irrespective of their baseline A1C or A1C target or metformin use. We kind of have to think of these as more cardiovascular risk reduction drugs rather than just diabetes drugs, since we know they also benefit heart failure and chronic kidney disease progression, especially in the case of SGLT2s. Inhibitors. So we prescribe them to reduce the cardiovascular risk mainly, but their hemoglobin A1C lowering happens to be a great secondary benefit. Another study looking at another SGLT2 inhibitor, which is empagliflozin, looking at the primary outcome of these, you can see that there significant reduction in MACE, significant reduction in death, improved survival, and reduced hospitalization for heart failure. Another, which is the Canvas trial, which uses Canagliflozin, which also showed that you had significant reduction in death, non-fatal myocardial infarction, or non-fatal stroke. So all of these outcomes that were measured showed benefit that favored the Canagliflozin, hospitalization, CV death, all-cause mortality. Similar to this, when you look at the Readiness trial, which also cuts the risk of renal failure. So this was a surprise that came out of by looking at the subgroup, the sub-analysis of these studies. When you look at patients who have an event, which means end-stage kidney disease, doubling your creatinine, or renal or cardiovascular death, which is the endpoint, there was a significant reduction in this endpoint when patients are on Canagliflozin. So basically, you show that these are a significant reduction by a hazard ratio of 0.7 in patients on the drug to reduce the rate of renal disease. Also, the secondary, it reduces the rate of death, MI, hospitalization for heart failure, cardiovascular death, and end-stage kidney disease. Declare study, which looks at dapagliflozin, which is another agent that also is shown to be similar to the prior agent, showing reduction in cardiovascular disease, heart failure with a MACE. MACE was not significantly different, but it did show a reduction in cardiovascular disease and heart failure. There is a DAPA-HF, which was also one of the looked at the patients with reduced ejection fraction, which again looked at dapagliflozin, which also showed a significant reduction in this composite: death, heart failure, and urgent heart failure visit. There was another, and these are the subgroup analysis of those where it was all the measured variables were better with dapagliflozin. There was an Emperor trial, which also showed that you had in patients with reduced heart failure or reduced ejection fraction, significant reduction with an odds ratio of 0.75 by use of empagliflozin. This was an interesting trial. So this is the Emperor preserved trial. So this is looking at patients who had preserved ejection fraction. They did the same study with empagliflozin, and they also showed a benefit. So this is the first study that was showed that with using an SGLT2 inhibitor in patients with heart failure and preserved ejection fraction is a game changer. So you have patients who have heart failure with preserved EF, they also benefit from SGLT2 therapy. There is a leader trial which showed that basically the first, now we move to GLP-1. So the GLP-1's liraglutide, this shows a cardiovascular benefit that looked at the patients from randomization and also showed benefit in these cardiovascular death, non-fatal MI, non-fatal stroke. Semaglutide, which is another GLP-1 inhibitor or GLP-1 agonist, which also showed benefit in non-fatal MI, primary outcome, which was tested here for non-inferiority and superiority. So both of those were met. And then non-fatal stroke. Death from cardiovascular cause was not significantly reduced, but again, a dramatic increase or decrease in 39% reduction in the risk of non-fatal or the risk of stroke, which was remarkable with this agent. This is a very interesting subgroup analysis of the semaglutide trial, which was published in just this year. So this was taking 1,900 patients with a body mass, obese patients with a body mass of greater than 30, or 27 with one existing weight coexisting condition without diabetes, 2-to-1 assigned with 68 weeks of semaglutide plus or placebo plus lifestyle. They showed there's a mean body weight change from 14.9% in the semaglutide group compared with 2.4% with placebo. There's a weight reduction of 5% more seen in 86% versus semaglutide versus 31% lifestyle only. So this agent also appears to have benefit in weight reduction. So not only does it help with the atherosclerotic events, it helps with weight reduction. So in obese patients, this may be an excellent agent to use. So looking at the cardiobedies team, you have the cardiologist, you have the primary care physician, nurse practitioner, diabetologist, other specialists, nephrologist, vascular surgeon. We're all working together to try to help patients. The clinician must be an important part of the diabetes care team. Again, we can look at these and try to come together to make lifestyle changes, appropriate guideline-based therapies to optimize cardiovascular risk in patients with diabetes. So key takeaways from this, basically most people with diabetes remain suboptimally treated for cardiovascular risk and will die of cardiovascular related consequences. The risk of cardiovascular events is heterogeneous in people with diabetes. The risk assessment is key. Further screening may help. Evidence points to blood pressure, lipid, glycemic control in patients with diabetes to reduce cardiovascular events. The newer agents have promise in reducing cardiovascular risk. The SGLT2 inhibitors appear to have hemodynamic effects affecting heart failure and cardiovascular death, which heart failure is not something that's been shown to be reduced with the GLP-1 agonists. But the GLP-1 agonists may have more anti-atherosclerotic events compared to heart failure benefits. So the diabetic care team, cardiologists, wide range of other healthcare providers. There's a need to reduce ethnic and socioeconomic disparities in diabetic care. So with that, I'm just going to turn it over to Mike so we can go do some case studies.
Thank you, Dr. Baker. So we have kind of 4 case studies, part 1 and part 2 for case study number 1. And I believe we're going to show a poll for the answer choices. So you'll get to kind of test your knowledge and see how others responded as well. So for case one, this is a 61-year-old white male smoker who has controlled hypertension and type 2 diabetes, recently diagnosed about 2 years ago, currently taking pravastatin 20 milligrams. You can see the most recent lipid panel there, showing a total cholesterol of 180, HDL cholesterol of 40, LDL cholesterol of 99, and triglycerides just south of 200. No prior history of heart failure or cardiovascular disease, so really a primary prevention patient at this point. Hypertension appears to be well treated with an ACE inhibitor. You can see blood pressure controlled. And diabetes is reasonably controlled with just diet and a recent A1C of 5.9%. So the question, what would be a reasonable next approach to optimize his cardiovascular risk? Okay, so maybe the old-fashioned way, you can raise your hand, even though I can't see you. There it is.
There we go.
Okay.
So just focus on maybe the case one poll for now. You want to make sure, just to answer the question there. We'll give it maybe a few more seconds. Someone's got to have some options, right? So if you haven't had a chance, please enter an answer so we can get to the rest of the case studies, please.
We can see the answers now, maybe. Results.
Yep, we're going to be closing the poll shortly. Cue the Jeopardy music. Okay, so it looks like of the people that voted, most want to recommend changing him to a high intensity statin. So if we can advance the next slide, please, Dr. Baker. So as the planning faculty, we thought, either increasing to a high intensity statin, or because he does have hypertriglyceridemia and it looks like his A1C is well controlled, either adding icosapent ethyl or increasing the statin intensity would be appropriate because he does have multiple risk factors, right? He smokes, he has hypertension. So increasing the statin would be an option. If the triglycerides were more concerning after adding that statin, then adding the icosapent ethyl would certainly be appropriate, given that he does probably meet the criteria for the Reduce-IT trial. Other panelists want to weigh in on their thoughts?
Yeah, I'll just kind of, so basically, yes. So if you have someone with this high of a triglyceride level, it is unlikely that they're going to get their triglyceride level down to the less than therapeutic or less than the value that are needed to ideal. But yes, but the goal is that if you can also, on top of that, of a statin therapy, which was the Reduce-IT trial, if you can reduce someone's risk of events by 28%, that's a great risk reduction. So this is why both are appropriate. I would suppose if you did change to a high intensity statin and then you did not get a reduction in your triglyceride, then you could add icosapent ethyl.
Yeah, I certainly agree with that approach. I think many of us probably would say, well, the first thing we might do, which is, has the most evidence based, is probably to move to a high intensity statin, right? That's been ingrained in the recommendations for a long time, but clearly, one is, we know from the Reduce-IT trial, you're going to get approximately another 25% risk reduction, perhaps even more than you would by actually adding a high intensity statin from adding icosapent ethyl. So really we'd like to see, people optimally treated with both being added. Whether you wait a little while before you add icosapent ethyl, I suppose you could, but ideally, as Dr. Baker points out, the high intensity statin is unlikely to lower that triglyceride. So if you go by the reducer criteria, this person would likely certainly qualify for icosapent ethyl.
Okay, on to the next one.
So follow-up, same patient, assuming that we're seeing him again and his A1C has gone up a little bit, but LDL did go down. Blood pressure has remained well controlled. He's now taking maximal doses of metformin. In addition to lifestyle modifications, would you recommend any of the other following changes to further lower his risk of cardiovascular disease? And we'll see if we can launch that poll again. Again, either A, B, C, or D.
Oh, the D was missing, it looks like. Unless if it's on the next.
Yeah, I think it's.
I have to scroll down. So just scroll down on that,
Okay.
and you'll get D
Oh, great.
on the right side of the poll.
Yeah. Oh, I see. Okay, people should have voted by now, so we can close the poll.
We tried to make these questions a case studies for patients that we'll probably actually see in our practices, or the type of patient we'll actually see.
Everybody should have voted by now. We can close the.
Okay. So it looks like we've got a split between adding ezetimibe or adding an SGLT2 inhibitor or a GLP-1 receptor agonist. Go ahead and advance that next slide, Dr. Baker.
Here you go.
We are kind of in agreement with y'all. If you're looking to tackle the LDL, I think ezetimibe would be a great place to start. We saw from the subgroup analysis that adding ezetimibe in patients with diabetes certainly reduce their risk more so than patients without. And we know from these magical drugs for diabetes, it's recommended to add on top of, despite A1C current control, because of their cardiovascular benefits. So others that have thoughts or comments?
Excellent. I think everybody
Yeah,
got that.
certainly makes sense. And then remember, even though the A1C is controlled, we are considering an SGLT2 or GLP-1 because of their cardiovascular risk reducing benefits, right? So I think that's a very important concept, that these are cardiovascular drugs, and a secondary benefit, as Dr. Baker pointed out, is their effects on A1C.
Okay, we'll move to case 2. Different patient, this time a 55-year-old female smoker with type 2 diabetes, and she does have a history of a previous MI about 5 years ago, recently hospitalized for heart failure 3 months ago. Also has CKD and a recent eGFR of about 50. She's been taking max dose of atorvastatin 80 on top of ezetimibe with a recent LDL of 90. Triglycerides look controlled about 100. So which of the following would you recommend for this patient to reduce their cardiovascular risk? So this is question 3 of the poll. We can make our choice selections in the next 10 seconds or so. We do have some Q&A we're trying to get to tonight. And again, if you have other questions, please add them in the Q&A section on the Zoom app below. Okay. Final choices. All right, looks like we've got a little bit more participation on this one. Can't wait to see the results.
Got the results?
Okay, so it looks like we've got 25% of folks saying to add the, oh, sorry, I'm the wrong one. Yeah, so some people saying add the PCSK9 inhibitor, and some people saying to add omega-3 fatty acid supplements. If we can advance the slide, Dr. Baker. Yeah, I think most of the folks were on it with adding the PCSK9 inhibitors. Dr. Wong, Dr. Baker, do you want to offer your perspectives?
Yeah, clearly this person is at what we call very high risk. So the, next obvious evidence-based therapy, given that the LDL is still, above 70, despite high-intensity statin and ezetimibe, according to the 2018 guidelines, would be a PCSK9. But I do agree that certainly this person would also, well, the triglycerides are not quite high enough to technically qualify for icosapent ethyl, although it's likely the person would probably benefit also from icosapent ethyl. We know that even in people with when their triglycerides are below 150, even though the study only went down to 135, you derive similar benefit. So the benefit of icosapent ethyl seems to be independent of the baseline triglyceride levels as well, but probably the PCSK9 would be the first choice.
Okay.
Excellent.
Move on to the next one.
And our final case study. So again, same patient, kind of a younger person at 55 with the previous MI. So in addition to lifestyle modifications, which of the following evidence-based cardiovascular disease risk reduction strategies would you choose for this patient to help her lower her blood sugar? Current A1C is 6.4, and she is reportedly adherent to her current metformin. So 4 choices there. Let us know what you think. What would you think about adding for this patient, or would you not add anything since their A1C is already at goal?
Should be easy for everybody to vote fast.
All right, so it looks like most people are recommending to add the SGLT2 inhibitor. I think that makes sense given her recent heart failure hospitalization. Any other faculty panelists want to weigh in?
Totally agree.
Perfect. Oh, and the CKD. Totally forgot about that. Yeah, so we're kind of hitting 2 birds with 1 stone there with the SGLT2 inhibitor. Excellent.
And remember the very important point that, we're not given these to lower the glucose. So even though her glucose is quite controlled, we're given these as cardiovascular risk reducing agents. So I think it's just a very important concept that these need to be positioned as cardiovascular drugs even more than diabetes drugs.
Yeah.
In addition to that, the history of heart failure makes an SGLT2 inhibitor a great drug. And if you remember the data from the chronic kidney disease, the dramatic reduction in prevention of end-stage kidney disease with the SGLT2 inhibitors, that makes this a clear choice because of the cardiorenal protection that you can also get with these agents as well.
Good point. Yeah. So we do have one question in the Q&A chat. The question is, what are your thoughts on the clinical cost of increased amputations with canagliflozin or Invokana?
Maybe I'll just make a few brief comments, and then if the rest of you want to pitch in. Well, you know, I think with any of these agents, we do need to consider kind of their net clinical benefit, right? So the amputation risk with canagliflozin, while it does appear to be higher with the other SGLT2s, so therefore the other SGLT2s have been preferred by many because of this increased risk. Still, the ultimate, you know, net clinical benefit is favorable because you're, you know, have the potential of preventing a lot more cardiovascular events, right? Your number needed to treat to prevent an event is more favorable than the number needed to harm in terms of amputation. But certainly amputation is an expensive, you know, expensive procedure.
Yeah, and I posted in the chat that black box warning about amputations was removed last year. And if you look at kind of our data, you know, we're looking for heart failure outcomes. Really, the only two SGLT2 inhibitors with kind of that hard endpoint of heart failure reduction in everyone was with empagliflozin and dapagliflozin. So if you don't want to use canagliflozin, you got other ones to use.
There was also a comment about the strength trial I saw in the chat box, and I might mention, so remember this was a large trial done that involved a combination EPA DHA agent, right? So it was a combination agent, and that trial was negative and was recently reported, and there were you know, there was some backlash about whether, you know, fish oil therapy is really helpful, but I think it's very important that we distinguish between those that are combination EPA DHA agents, and none of those trials have been shown to have benefit in terms of cardiovascular outcomes. And none of the dietary supplement clinical trials have shown benefit, nor are there any well-conducted ones. So the only benefit that we have from fish oil therapy is from pure EPA, as demonstrated in the JELIS trial originally in Japan and most recently in the multinational REDUCE-IT trial. So our patients really need to understand that not all fish oil is the same, and the only one that has actually an FDA indication for cardiovascular benefit is pure EPA icosapent ethyl. So very important people understand that and not confuse this with dietary supplement fish oils that oftentimes have impurities and even saturated fat impurities in them, and the EPA DHA combinations fail to show benefit.
Excellent point.
All right. Well, I don't want to keep anyone any longer than we need to. So don't forget to click and complete both links posted there for your MOC credit within 30 days. And I believe you will be receiving an email with these links within sometime this week, so that you can complete the evaluation and the MOC link to earn and achieve that 1.25 credit. So on behalf of ACC, California ACC Prevention Committee, thank you for attending this webinar.